Hi everyone, welcome to LA Appendage Closure course, which is something which we all sat together and thought that we should start. It's high time that in India and the region around we do some of these courses to enrich everybody. And today it's our pleasure and it's an honor to actually have Dr. Horst Sievert. I think he doesn't require any introduction in this part of the world. Most of us have attended his CSI conference, and he's a real master in LA appendage closure. Knowingly or unknowingly, I think all of us have learned something from him, and it's something which is imbibed today. So what we are going to do today is we are going to. This would be there would be 3 such series in this year, almost separated by a month. So this is the first one where we are going to discuss some of the basics and we are going to learn some tips from Dr. Horst Sievert. And we'll also have 2 other presentations, one by Dr. Purohit and one by Dr. Hazra. So this is the purpose, but we want it to be much more interactive. I'm also very happy to share that we have participants from 85 countries and more than 350 registration. That's round the clock, and that's something which is really encouraging. So without wasting my time, I think we will start off with today's discussion and session. So the first talk will be from by me, where I'm going to discuss about device planning and some of the indication a little bit. And the second talk will be by Dr. Horst Sievert. So I'm going to give as much time as possible to Dr. Horst Sievert, and I will also be very happy if you could ask your questions and discuss with him about how he handles difficult anatomy. The simple cases are always easy, but with LAA you have no choice. It's not like coronary. In coronary, once the angio is done, you can always choose. I will only do type A for first 100 cases and will do CTOs after that. Whereas you just can't do that for LA because they're all it's so unique and it's so variable, so that you need to learn most of the tips and tricks right from the beginning. So I'm going to start with my talk, which is going to be short, and please make it interactive. Please make sure you type in your question, ask us. I'll also request Dr. Purohit and Dr. Hazra to be very actively participating and asking questions. So I'll just start with today's talk, which I've made a little different from my previous talks. So I hope my slide is visible. So first, let's start with AF itself and indication for this procedure. And we are going to put some of these questions to Dr. Sievert later. We all realize that AF is very, very common, and with aging population world over, the cases are only going to increase. It's not the irregular rhythm which matters, but it is the stroke which it produces which really matters. And the stroke produced by AF are much more dangerous. There's more disability, there is more death. And if you have to choose, that's where the problem comes. But there is an effective therapy, which is being oral anticoagulant, and now we have what we call as a direct oral anticoagulant. All these are available, but there's still challenges because WAF has very narrow therapeutic range and it's very difficult to monitor it. There are lots of interaction, especially in countries like India, which is predominantly vegetarian. So it's very difficult to actually tell them that you have to restrict green leafy vegetable and take WARF. Frequent monitoring is needed, and it's very erratic. So there was always a need for an alternative therapy, and that therapy is LAA closure. So 2-3 questions we should answer is why LAA? I mean, we talk about AF, but why are we talking about left atrial appendage? The data tells us, although it was a smaller study to start with, which actually tells when we talk about non-valvular AF. So this is one question which we need to answer right away. What is non-valvular AF? Any AF other than the prosthetic valve or other than mild, moderate or severe MS. That means if you have traditional non-valvular AF, HOCM AF, MRAF, ASARAF, that's also considered as non-valvular. In these conditions, the clot is predominantly in appendage. So if there is a way, if you can safely exclude appendage, then the stroke risk comes down by 90 to 95%, which would be similar to what any drug would produce. It could be warp or could be newer drug. That is the rationale, and then there were trials of Protect AF, Prevail. There are registries called Evolution Registry. We could discuss all that, and that is where the data comes from. Now, what's been the world over indication? Who are the people world over who are receiving this therapy? Because after Protect AF, it was actually approved. After the Protect AF followed by Prevail, it became FDA approved procedure. But in US, it was traditionally recommended for people who could take anticoagulation but didn't want to take for whatever reason, didn't want to take or couldn't take. They were the patients where LA was recommended. But if you look at the trial data, it's actually most of the time as alternative to anticoagulation. So that's been some sort of a paradox in this condition, because most of the time world over it is actually used for people who cannot take anticoagulation. But that's not been studied in a randomized trial. In the randomized trial, the study is actually as an alternative to anticoagulation. But if you look at world over prescription, it's predominantly, this is the European experience, which shows that 94% of people who actually receive this therapy have higher CHADVAS and have clear contraindication to oral anticoagulation. Sizable percentage of these people again have high CHADVAS, has high bleeding risk, but have not bled. There are around 5% of patients which is very high risk. They are on very optimal anticoagulation but tend to have recurrent stroke. This is one group where this therapy could be beneficial along with anticoagulation, and 1% of the world actually receives it as an alternative to anticoagulation. I want you all to just look at this slide that we know CHADVAS score, which is the very standard score now. Score more than 2 is an indication for anticoagulation, either with warp or with newer drugs. But if the problem here is if you see the left side and the right side, most of the parameters are just same, they're just repeated. So that means most of the time, very patient who is at high risk for clotting is also at high risk for bleeding, and that's where the people don't receive enough anticoagulation, and that is the problem. This was the 5 category which I had described. Most of the time it is high thrombotic but contraindication, and sometimes it's used for people with high bleeding risk. Then very rarely it is used for people who can actually take anticoagulation. Now, the question which we need to probably answer here is, what are the important question which I feel is, whatever indication you take, all of us will have patients who require this therapy, and that's why it's very important for us to understand how to do this procedure and give it to appropriate patient. So the indication could vary among the physicians and could vary according to geographic area, but there's no doubt, because of the burden of the disease, everybody would have some patient who require this therapy. Now let's go a little bit about planning. Once you decide to do it, how do you plan it? These are the traditional classification of LA. As I was starting to tell you in the beginning, you can't be choosers here. It is highly variable. It's as variable as the fingerprint. That means it would vary from one person to another. You could classify into whatever you want, but it is variable. The good part is, now that people have overcome their learning curve and people are little familiar with what they do, the good part is, whatever be the anatomy, you could have any of this anatomy, but whatever anatomy, whatever device you have in the lab, it's still possible to use, whichever device you have in your shelf. 99% of the LAA can still be closed. That means in today's era, you do not need to have multiple devices in your shelf. Whichever device you have most of the time you could close with whichever device you have. So that's a good part, because that number was 87% in Protect AF trial, but over the period that number is increased. Now we have understood to make it better. So whatever anatomy you have probably doesn't matter, because you're still able to close most of them. Now, imaging is extremely important for this procedure. There are people who would do pre-imaging, would do a T pre, do a CT pre. Most of the time in our centers, we do not do pre-imaging. I do the imaging on table, but before I take a puncture, because it's so dynamic, the measurements and the sizes really doesn't matter. So but wherever we go to proctor, we request them to do one T just before, to rule out LA clot, because you most of the time we do not want to be doing this procedure when there is a LA clot which is already present. With the small exception, we really do not want to do, because this is the procedure where you're trying to prevent a clot and a stroke. So you do not want to be inducing it while doing the procedure. So imaging becomes extremely important. That means we need to realize it's a two-person procedure. You need to have a sonologist, a echocardiographer, a cardiologist who is well versed in imaging and who can guide you very well during this procedure. Now, these are the different views which needs to be taken. So you need to take a 0, you need to take a 45, 90, and 135. So you need to take different views here. And then, based on these views, you will be deciding what what size of device which you will be implanting. So this is where it also depends on the type of device you want. So if you have to broadly classify the device which are now available in India, one is a body specific device like Watchman device, and the second is the device which is predominantly put in the neck. So those devices include ACP, amulet, and lambre. So today I think we are going to discuss a little more about lambre, and in the coming sessions we will be discussing about different devices. So based on the same appendage, depending on the device, depending on the you will get a different number, and you're going to measure it differently. The measurement which I have shown in this picture is actually mainly for Watchman device. So if it is a Watchman device, it's going to land here. Circumflex is a very important landmark, and it's going to land at this juncture. So you get one measurement which covers the body, which we call as a landing zone or a zone where it's going to land. You're also going to measure a depth. You're going to get this number in different views. You're going to get it in 0, 45, 90, 135. And for Watchman, say this number is 22. You would add 4, that would make it 26. Then you would go with 27, the next size, or a 31 device. And I think Dr. Horst Sievert will later add his wisdom here. He always upsizes by 2 sizes. Most people in the most people would upsize by 1 or 2. It also depends on the depth. If there is enough depth, it's always very important to upsize as much as possible. But if you're taking a device which would sit on the neck, that would be ACP, amulet, or the lambre, the measurement would be different. In which case, we would measure somewhere here. You would measure the ostium, you would come 10 millimeter in. That's where most of these devices will sit, and you will measure here. So the point I'm trying to make is, it's not one number, there are many numbers. So those numbers come based on the device you choose. So since we are trying to do lambre today, let's discuss what is that number for lambre. For lambre, the measurement would be here in the area of the neck at level of circumflex. The number would be here. So this number you measure in multiple views, and beyond that, upsize by around 3 to 4 millimeter. Lambre is an extremely soft device. It's more helpful. It has 2 components. We'll come to that. So a little more upsize would work extremely well for lambre device. Angiograph is not that important to measure. It is actually the echo, which helps us and which measures. So if you look at here, this is the circumflex, and this is the measurement which you will take for lamprey in multiple views. And once you get multiple views, upsize by 3 to 4 millimeter. And these are the different angiographic view which shows, and this is actually a Watchman device which is put. So if you're using lamprey, how does the device look? The device has two parts, the body and the disc or cover, what you call it as cover. This has this, the way lamprey differs from the ACP or amulet is it does have one more covering double membrane which is in the distal part. Hence, even with little smaller clots, you will still be able to use lamprey. It's softer. The sheath what you use is 9 to 10 French. It's softer than other device, and this is how it looks. This part with the which has a PET membrane is the one which covers. So endothelialization is much quicker. It does have hooks. What we should realize is almost all LA devices do have hook which would grasp the left atrial appendage. Most of the non-hook device got actually withdrawn because the embolization chance is higher. So almost all the current existing devices do have hook, and here there is double protection because you have a hook, you have a nitinol frame, you also have a disc which now covers the ostium of the left atrial appendage. It comes as a single curve, comes as a double curve. Most of us use 95% of our case is actually using the double curve. These are the hooks which are visible here. They are very tiny. So we have to be a little more careful, but if you are handling it well, chance of pericardial effusion is not much. These are animal models which actually shows how these barbs open and how they hold on to the left atrial appendage. And this is how it used. Lamprey comes in two sizes. One is called standard size, which varies from 16 to 36 millimeter, and the cover, the disc, what we call is 4 to 6 millimeter above. Sometime when you have a very early low, see, the advantage of lamprey is it would probably be suitable for 99.5% of the left atrial appendage, because any appendage it would work. So even if you have an early lobe, this is extremely difficult for any other. If you have a lobe like this, any other device, this is difficult to close. But if you have an early lobe, better to they have what is known as special devices where the lobule of the device is smaller, but the disc is larger. So you could use the disc to cover the ostium, but use a smaller lobule to anchor into one of the lobe. So there are some options which are available. So as you image, you could plan which where exactly you could use special devices. The special devices are very useful in bilobe, shallow, extreme sizes or combination. Most of the time, the other one actually is like ACP amulet, so it could be used in standard cases. Now, how do we deploy it? This is just a cartoon telling us how to deploy this device. So we have already chosen the landing zone, which is in the neck, and this is the circumflex. So you want to be slightly within circumflex. So most these devices, you open it in left atrium and slowly, it's like an umbrella, and you slowly start pushing it here. As you push, maintain an anti-clockwise torque so that it aligns with the neck of left atrial appendage and unsheath it further. So once you push, once you know the position, once you are at the landing zone, so you push until you reach the landing zone. Once you are at the landing zone, start unsheathing the sheath with anti-clockwise rotation. As you do that, you realize that your device is now stuck, the lobule is stuck, and the disc is now covering. And most of the time, you need to have that little tug on the disc. It should look like a pacifier. The kid usually never takes away is not able to throw out the pacifier because there is a constant suction. So one of the mechanism how these devices are held in place is actually by this mechanism. Among the devices, this is easy to deploy and it is safer because you're not going two in, and it's more forgiving. The size variation is allowed, it little more forgiving. So just to demonstrate the same thing, you're bringing the hooks out of the sheath here, you're slightly pushing it in, you're reaching the landing zone. As you reach the landing zone, you're unsheathing it further, and more unsheathing will actually lead to opening of the disc. At this point, find out that it's stuck, it's in position, the movement is only in this. So slight open, partially open, take it to position, keep the anti-clockwise torque, unsheath, and then check whether the layer is fully covered. So this is uh, how it is done. Now, angiographic landing zone is not important. I think in your mind you should take it off. It's extremely important it to be an echocardiographic procedure. So this is what we were discussing. This is where the disc will sit in echo, and this is where the lobule, the device, will sit. And the depth is not very important for this device, but it is important for other device. Radiopic markers are seen. You look at the echocardiographic again, decrease the grain, and make sure there is no peri-device leak. Current deployment should not have peri-device leak. As much as possible, we should have it zero. Although most studies do allow between 3 to 5, but it's better not to have any peri-device leak. So in general, it is 2 to 6, around 4 millimeter upsize is what we do after measuring landing zone. More oversizing can be done, and special devices are used in bilobed and very shallow LAA. So this is the sizing example. D1, D2 is where the disc would sit. D1 is your landing zone. Measure D1 in multiple echocardiographic view and upsize by around 4 millimeter. Around 4 should be your rule. So we will discuss other things in question answer, but this is how this is done. So let's see one case which we have done recently. So the first step is the septal puncture, which remains same. Whatever device you use, it is the first step is the septal puncture, which we do. So here we had to use modifier technique. This is not. So the septal puncture is done under TE guidance, and the septal puncture has to be posterior inferior. That means your puncture is in bicable view, it has to be towards IVC, which makes it inferior, and in aortic view it should be away from aorta, which makes it posterior. Posterior inferior puncture is very optimal because it makes you to take the device directly into the appendage, which is left anterior. So here after puncture, we had little problem entering LA because that part of septum was thick. So we did put a Innova wire, and then on the Innova wire, a 9 French sheath was taken. Typically, we don't do it. If the puncture is easy, you can just take any wire you want, but very rarely you end up with problem like this. There would be too much tenting so that your puncture position is not fine. So here in this case, we used Innova wire. We went to left atrial appendage and then changed it to a 9 French sheath. And after that, always use a pigtail. Never move into appendage just like that. Your sheath should not be moving into appendage. It should always be led by pigtail most of the time and rarely by device. If you are learning one thing about left atrial appendage is to respect it. It's a very thin structure. It's something which is very delicate. So respect it well. Do not be very harsh. It is not as forgiving as the coronaries which we do, but we need to respect and we need to treat it very delicately. And then once you are in, we were already there. The device we slightly opened, took in and just like the demonstration, kept an anti-clockwise sheath, unsheathed it and released it. This is the septal puncture. Here the septum was extremely thick, and that is why we had to alter our technique of entering the left atrium. Most of the time, you still have those thin areas of the septum which we didn't have it here. And then this is how the device looks. So device is released here, and this is the disc. It's beautifully covering the left atrial appendage. The 3D showing that the disc is completely holding and there is no para or peri device leak. What do we do after? Make sure, just the dual antiplatelet is enough for most devices, although Watchman based on Protect AF actually showed, they give anticoagulation. This was the success which we are talking about. Initially, it was 87.5, Prevail at 95, Evolution at 98.5, ACP Registry at 96, Lambre Global Study, the success is actually higher, 96.6. So with time and with learning, now our success for this device is high. The acute closure rate is high. The peri-device leak is now minimal or negligible, and overall complications have come down. So like all other procedure, there's a learning curve, but once you overcome it, the success is higher. So Lambre has more stable anchoring. It's fully retrievable. Sheath used is small, and rapid endothelization is same. So with this, I think I will stop my talk now, and there are some questions, but I think which we will take it after Dr. Horst Sievert's talk. So now I request Dr. Horst Sievert to deliver his lecture, and then I think we'll take some questions, then we'll go for a case. Over to you, Dr. Horst.
Yeah, thank you very much, and thank you again for the invitation. So my topic is actually more the problems of this procedure, and I will explain why. And so why is the title of my talk, No Room for Error? And the reasons are that overall LAA closure is, as you have just told us, a very safe procedure. However, it is a prophylactic procedure. That means patients do not have any symptoms or complaints, at least at the time when we do the procedure. On the long term, of course, patients without LAA closure will get more bleeding complications, but it may take months or years until they occur. And therefore, LAA closure is really different from most other interventions we do in the cath lab, like PCI or TAVR or PTA. Those patients have symptoms, and when they leave the hospital, they have relief of their symptoms. And here, the only thing what they can get during the procedure and when they leave the hospital is complications. And that's why it's so important to avoid complications. Now, what are the most important complications of LAA closure? This is just the list of the most frequent events which can happen. Pericardial effusion or tamponade is the most common complication. Then thromboembolism or stroke, air embolism, and device embolization. So these are the things you have to keep in mind. And when it comes to the question why the penetration of LAA closure is so low, although we have so good evidence, these complications are one of the reasons, because many of us have run into one of these complications and then we hesitate to continue our program. And thrombus on the device is a complication which does not occur during the procedure, but which can occur later during follow-up. This was the first ever attempt of an LAA closure. That was in August 30, 2001. 66-year-old male patient, atrial fibrillation since 1 year, had a history of stroke, history of severe bleeding on Coumadin. CHUD score was 5. And this patient suffered from a tamponade. And probably this was caused by a multi-purpose catheter in the left atrial appendage. We said, don't go in with a sheath into the appendage, which is true, but also multi-purpose catheter can cause perforation. I was at that time not really sure about the cause of the bleeding because I didn't realize when the bleeding started. I just saw the pericardial effusion, the tamponade later on. What we did was immediate pericardial synthesis and drainage, and we retransfused the blood via the femoral vein. The procedure obviously was abandoned at that time. An hour later, we did the second case, which was in the history of LAA closure, the first successful LAA closure. And the first patient, well, he could be stabilized, pericardial drainage could be removed the next day. I told him that we would try this again in a few weeks. And this patient said, why didn't you just put the device in to seal the hole? And the second procedure in this patient was done a couple of weeks later on, and this was successful. So we learned all we need to know about tamponade from this very first attempt of LAA closure. First, it's often difficult to say what the cause of the tamponade was. There are other potential causes. If it occurs, try to finish the procedure and implant the device as recommended by this first patient. And pericardiocentesis and retransfusion often solves the problem. So this is a case example, a 75-year-old patient, paroxysmal AF since less than 1 year, some concomitant diseases, CHAD score was 4. This is transeptal puncture performed under TE guidance. These are the measurements. So we measured in 0 degree, 23 diameter landing zone, and 33 length of the appendage. In 45 degree, we measured 17, length 29. These are some angiographic images. The LA ostium diameter in caudal projection was 19, in area caudal projection was 24. So looking at the sizing chart, this was a patient where we closed the appendage with a Watchman device. We measured 23 on TEE, so that would end up in the 27 millimeter occluder, and also on fluoro, the largest diameter was 24. So a 27 millimeter Watchman occluder was the right size to go. This shows you the implantation of the device, some images from TEE as well as from fluoro. And this is the tug test. So we pull on the device to make sure that it's really engaged in the appendage. This is the final angiogram before release. So we look for the proper position. This is compression, device measurement on compression TE, 19 millimeters, on fluoro 20 millimeters. So residual compression was okay. We are looking for at least 10% residual compression. This is the final position of the device. So overall, a 25 minutes procedure, fluoroscopy time 7 minutes, contrast use 100 cc, initial bolus of heparin was 10,000 units, very small pericardial effusion on day 1, control TEE on day 3 showed no pericardial effusion, post-procedural medication with Coumadin according to study protocol, discharge from hospital on day 4. So you may ask me, where's the complication? Well, on day 10, this patient came back to the hospital with left thoracic pain. EKG was normal. Fluoro showed the correct position of the device. Transthoracic echo showed a pericardial effusion of 2 centimeters with swinging heart. And I could tell you this video is not playing, but in fact, we did not record this because we had to do something with the patient. And the question is what to do now? Well, we did pericardiocentesis. We aspirated 100 cc of bloody fluid, pericardial drainage for 2 days. TTE on day 12 showed very small residual pericardial effusion, and 3 years follow-up in this patient was uneventful. So what are the possible causes of pericardial tamponade? Transeptal puncture, of course, access to the left atrial appendage, as we discussed earlier, implantation of the device by itself. The device itself could cause pericardial effusion, like in this case example, and anticoagulation plays a role. So how to prevent tamponade? Transeptal puncture always under TE guidance, or you may also use intracardiac echo, of course, but that's too expensive for India as well as for Germany. So we use always TE, and the reason is to use TE also that we also have to rule out thrombus before we do the procedure. So there is no advantage to do the transeptal puncture under fluoro control only. Access to the left atrial appendage, start with an angled pigtail, exchange over the pigtail or an Amplatz extra stiff wire, and do the appendogram with wire or pigtail in place. And how to manage tamponade? When this occurs acutely during the procedure, then pericardiocentesis and retransfusion is the way to go. If it is chronic, days after the procedure, like in our case example, then also pericardiocentesis, but without retransfusion, because you may encounter old blood, and if you retransfuse that, you can cause a lot of clotting problems. Surgery has been performed in many cases, but I think it's really rarely needed because when you send these patients to the OR, the surgeon usually has difficulties to find the perforation hole, so he just opens the chest and then closes it again. So it's usually sufficient to do pericardial synthesis and aspiration of the blood. Does anticoagulation play a role here? Anticoagulation is, of course, never the cause of bleeding, but it does make it worse. So that's why we always stop anticoagulation before we do the procedure. We give heparin only after successful transeptal puncture. The only exception is we give a small dose of heparin if the transeptal puncture is very time-consuming. And we give protamine in case of pericardial infusion. We can stop here. If there are any, I can't see the chat here from my view. Are there any questions from the panelists or from the chat from the attendees regarding how to handle pericardial effusion and tamponade? If not, no questions? Then
yeah, I think there's no question about tamponade. There are other questions. We could take it, I think, later once you finish the talk.
That's fine. So the second complication we are afraid of is thromboembolism and stroke. And what are the potential causes of thromboembolism and stroke? Thrombus in the left atrial appendage, thrombus formation inside of the transeptal sheath. And this happens if the transeptal puncture is difficult and takes more time than usual. The thrombus in these cases forms in the space between the needle and the dilator. And then thrombus formation inside of the delivery sheath, which comes with the device, it's another potential cause of thrombus formation. How to prevent thromboembolism? Thrombus in the LAA, in my view, is a contraindication. And I saw some comments in the chat that it is possible to close an appendage with thrombus inside. Yes, it is possible, but I think we should really avoid that because in our experience and the experience of many other centers, if you just wait a couple of weeks and months and give some sort of anticoagulation, these clots are disappearing over time, and then you can bring back the patient and can do the procedure much more safely than when you go in with a device or the sheath into the appendage where a clot is sitting in. Always flush all catheters and sheath intermittently or with continuous infusion. And for the lumbar device, in fact, continuous infusion is very important because this device is introduced by a very small sheath. So if you don't do flushing continuously, then you have other problems like air embolism. So it's important to do flush of the catheters. Give a sufficient dose of heparin. We usually give 10,000 as a standard dose, and then we do not measure ACT because we know that we are finished within 30 minutes. But if you may take longer time or if you want to be even more on the safe side, then you should do this with ACT controls and you should target 250 seconds. Air embolism, how to avoid air embolism. You always should de-air the sheath very carefully, and this is obviously a major difference to most other procedures we do in the cath lab, like coronaries or TAVR and so on, because we are working in the low pressure system, so air embolism is a real risk. How to de-air the sheath, you should wait for back bleeding, you should not aspirate because in most systems, if you aspirate, there are small gaps in the valve where you actually suck in air, so it's better just to wait for back bleeding. And you should always stay with the hub of the sheath below the level of the heart, and this makes the back bleeding much easier. And also LAA pressure should be higher than 10 millimeters of mercury. How to do that? Well, you should not do this procedure in a patient starving all day and then do it in the afternoon. You should give them fluids during the day by infusion or do it in the early morning where the LAA pressure usually is higher. If air embolism occurs, how to treat that? Well, the first thing you should do is give him oxygen because that helps them to get rid of the air. Heparin to avoid additional clot formation due to the air which is sitting somewhere. 2B3A inhibitors, sometimes we give that in addition, or lytics if we have really a major problem, but that's rare. So usually oxygen alone solves the problem. Then device embolization. Well, this is a case example, a 66-year-old patient, permanent atrial fibrillation, hypertension, diabetes, and some other diseases. Not so important here. SHAT score is 2. We did some measurements. You see the angiographic measurements in areal projection 22 and 24, in areocranial 22 and 18, and echo 17 and 19. You can see that these measurements are very often different depending upon the technique and depending upon the view where you measure. And in this case, we have all kinds of measurements with TE 17 and 18, which would mean a 21 millimeter occluder, but on fluoro 18, 20, 22, and 24, which would mean a 24 millimeter occluder. So this is the implantation of a 20. We always go for the largest according to these measurements. So that is a 24 millimeter Watchman. We measure residual compression. We do check the position. We do a tug test. That means we check whether the device is in a stable position when we pull. And this is the long axis on echo. It looks stable. And this is the short axis, 45 degree. It looks stable. And then it was not stable anymore. And the echocardiographer said at that time, look at this, very nice images. And so the occluder ended up in the aorta, and most of the embolized LAA occluder go to the aorta. And the question is what to do now. What are the options? Maybe the panelists can comment. What would you do if you see this occluder in the descending aorta?
Yeah. Dr. Hazra, would you like to? Dr. Hazra, Dr. Purohit?
Purohit.
Yeah.
What would you do? You're muted.
Yeah, if you see that there's an occluder, something like this, which has come into the abdomen, definitely we will take a larger sheath which are there and try to, because these are all self-expanding devices. You can try to catch at the hub and try to take it out using a snare or something like that.
Yeah. So actually, many of these occluders have been removed by surgery. And actually, I remember the AMULET trial. They had 3 cases where the device embolized to the descending aorta. They sent them to surgery. And I think 2 or 3 of them died after this procedure. Other techniques to solve the problem is to implant a big stent to compress the occluder to the aortic wall. That is actually working, but you have to be careful and obviously not to cover visceral vessels or renal arteries. But I totally agree that the therapy of choice is really to get it with a snare. And you have to think about where to snare, where to grab these devices. And this is obviously device dependent, where to grab it. And this shows you a snare and a big sheath. We always go for an 18 French sheath when we have that situation. And it was easy, actually pretty easy to, with the old Watchman, I think that is the Watchman which is still available in India. It's actually easy to grab them anywhere, and you can pull them back into an 18 and probably also into a 16 French sheath. So why did it embolize? And here it's clear. I mean, you had paid attention, I'm assuming, and I showed the residual compression, which was 23.5 and 24.8. So basically, there was no compression at all. And we made the mistake that we thought, oh, the device is looking in a good position. The tug test was okay. So we didn't really pay attention to the residual compression. But we learned from this case that residual compression with the Watchman device is actually very important, and you should never leave a device in if it is not compressed. So this shows you the diameter we would have expected, at least a maximum diameter we should have tolerated was 22. Compression should be 8 to 20% with the Watchman. So we then went in again in this patient with a 27 millimeter Watchman device, and you can see here there's an inferior gap. You see this here on the angio, that there is a gap right here where the device is not really touching the wall. And this could also be seen on TEE. What you also can see is that this device now, it's not only a bigger device, but by chance it was implanted more deep into the appendage. And then we saw this gap here. So we repositioned the occluder, repositioned it, pulled it out a little bit, redeployed it. and then this gap was closed. And next one. You can see that now we measured compression of 18.3, and this shows you one of the problems. It's not only the size of the device in relation to the landing zone, it's also the question, where is the device implanted? Is it more deeply implanted or more outside of the appendage implanted? So we have here now a compression which would have been sufficient for the 24 millimeter Watchman device. And this is the tug test again. And this is the release of the device. This shows you in different views the angiographic result. And the echocardiographer, interestingly, at that time said, it looks okay. So she did not say, it looks great, just okay. Anyway, any questions regarding device embolization so far? In the chat, maybe? I can't see the chat. But if that's not the case, then we can go to the questions later on.
Yeah. I think there are one or two questions, Dr. Horst. There's one of them was about the pericardial effusion. So it's about after you spoke about the experience of first patient. If there's a controlled pericardial bleed, would you just aspirate the blood from the pericardium, auto-transfuse, go ahead with LA closure? I wonder what will be your anticoagulation strategy? And then continue to closure LA without heparin ACT less than 150. And you could probably guess the person who asked the question. It is Dr. Sivakumar. You know him well. So this question is from Dr. Sivakumar. Yeah.
When we see perforation during the procedure or tamponade during the procedure, the first thing, whenever possible, is really to implant the device. Because you have a good chance that by implanting the device or finalizing the implantation of the device, you can seal the hole. And then the second step is pericardial synthesis. And in that situation, we always retransfuse, because to wait for blood cell transfusion takes by far too long. This is very rapid, and you have to do something immediately. And if you just aspirate the blood, you will aspirate 1 liter, 2 liters in a very short time, and the patient will lose all his blood. So it's very important to immediately retransfuse this aspirated blood into the venous system. And then, when the device is in place, and then you can leave the patient without any antithrombotic treatment for a day or for 2 days. Actually, in the evolution trial, we have seen that the incidence of clot formation is not really much worse if you don't give any medication after device implantation. So I would, in that situation, I would withhold any antiplatelet therapy or anticoagulation for 1 or 2 days until I see that the patient is stable.
Okay. Thank you, Dr. Horst. There's one more question by Dr. Karthik Kesan. Any tricks while deploying the device to avoid effusion?
I think the most, we went through the different reasons for pericardial effusion, and one is transeptal puncture, one is entering the appendage, and one is device implantation. It's at the end of the day, it's always, when it comes to the LAA, it's perforation of the distal part of the appendage. So you should not advance the sheath without any protection by a wire or by a pigtail catheter, or you should do it very, very carefully, because that is the moment where you can perforate. And then also when you have the sheath in place and it's deeply engaged in the appendage, and you push out the device without paying attention where it is, that's also another reason why the device can perforate. So I think with the sheath or with the device, you have to be very careful when you advance it into the appendage.
There's one more question by whether you could inject a dye and identify the site of leak in LAA. This
sometimes,
is by the,
Yeah, sometimes, yes. So when we see tamponade and you do the angiogram, sometimes you can see the perforation, and that makes you sure that the problem is at the LAA, which again is a reason to finish the procedure as quick as you can. The other reasons, like pericardial effusion, can happen due to transeptal puncture. For example, if you puncture too inferiorly, there may be a way to puncture through the pericardial space into the left atrium. And this also can be a cause of tamponade. But that's something you cannot see by angiography. But if you have perforated the appendage, usually you can see this by angiography. But it's not so important because, again, the first step is always to implant the device because also you want to finish with your procedure. And the second thing is always pericardial puncture. And then whatever it is, you have to continue with aspirating the blood and retransfusing it until the bleeding stops. So regardless what the reason is, even if the reason is somewhere else and not in the appendage, it's the same technique. Well, having said that, if the cause of the pericardial effusion is going by the transeptal puncture through the pericardial space, those patients usually develop the tamponade not during the procedure, but later on when you pull out the sheath. And if you are aware of that reason, then you should go in again through the same puncture hole and close the puncture hole with a device like a PFO or ASD device, and that usually seals the hole into the pericardial space.
Like a stitch artifact, like a stitch going through the RA and then, going to the pericardium and coming back to LA, that kind of,
yeah. And that can happen because we want to puncture as inferior as possible for technical reasons, because that gives us the better access to the appendage. And if you don't pay attention, it can happen to puncture the pericardial space. Yeah.
Yes. There's one more question by Dr. Shivakumar. I think it's that if you find an organized clot in LAA, after months of warp therapy, would you still close the LAA, or would you aspirate the, can you put the sheath? And I think it's about closure in organized clot. Yeah.
Yeah. So yes, you can do this, and we have done this. There are different things you should consider. First, you may be first of all, when you see a clot, you wait until it resolves. If it does not resolve after 3 months or 4 months, you can assume that it is organized. Still, you could go in with a big sheath, like an 18 French sheath, and try to suck it out. That's the technique we also use for treating pulmonary embolism with a very big sheath. Just go in and aspirate as strong as you can. If it does not come out, then you can go ahead with a closure device, but you should select the device you are going to use. I would not recommend to use the old generation of the Watchman device, because with that one, you have to go into the appendage as deep as you can, and that would potentially mobilize the clot, even if it is organized. I would use a device where you can start the implantation in front of the appendage, like the lumbar device, for example. And that ensures that you don't mobilize the clot.
Yes. So is it more difficult to snare a embolized amulet or ACP compared to Watchman? The question by Dr. Chakrabarti.
Yeah, ACP is a little bit more difficult to snare because you don't really know where to grab it.
There's one more question by Dr. Yadave. Do you use deflectable sheath for LA closure?
Not routinely, but in some rare cases, it's a good idea, actually, yes.
Yeah. There's one more question is how inferior and posterior is safe on TE to prevent stitch defect? Yeah.
Or you should just be a couple of millimeters away from the inferior edge of the septum should be sufficient.
Yes. And preferably, probably you're still in the thin area of the septum and not in too thick area.
Exactly.
Yeah, it's the same question. I think single curve or double curve, what's your preference for LA closure?
That's a very good question. So when we started doing LAA closure with the Watchman, before that we had only one sheath, which was the plateau sheath. I didn't know what to use. So I thought double is better than single, and I used the double sheath. And it always never happened that I had to change. So that's why I continue to use the double curve.
Right.
Others started with a single curve, and they never had the reason to change. So they continued to use the single curve. double curve and then was successful with the anterior curve.
Pleural effusion anytime? The question by Dr. Prakash.
No, pleural effusion, I could not imagine how this can happen. Was this during the procedure or later on?
Yeah, it's instead of pericardial, like a stitch, you have had pleural. I think that's the during septal puncture probably. Yeah.
We did not have that. I mean, what I could imagine is we had type of complications, a kind of a chronic pericardial effusion, like a post-cardiotomy syndrome. And that, if that happens, it's very rare. But if that happens, that could also affect the pleura.
Problem. I think the next question by Dr. Gautam Datta is, would you choose different devices according to LA anatomy or,
Well, I think you highlighted an important difference for the lumbar device, which can be used if you have a bilobed appendage or a very, bilobed or trilobed appendage. Sometimes other devices are just not suitable, and the lumbar device has this special version where you can go into one of the lobes and then have a big cover which covers both lobes of the appendage.
Yeah.
Others, I think, the different configurations of the appendages are not so important because it all depends upon the landing zone. If you adjust, the landing zone is important. The only difference is for the transpericardial technique, the Lariat technique. There, the morphology of the appendage by itself is important. But for the devices, it's not important.
Thank you, Dr. Horst. I think we will go on and we'll take the questions as more pour in here.
I will shorten my presentation a little bit because otherwise we are running out of time. So very briefly, how to prevent device embolization. I already mentioned that the LA pressure should be higher than 10 millimeters of mercury. Why? Because otherwise the appendage is not fully expanded, and then you measure a smaller diameter and then you pick a smaller device. So that's the reason why this is important. All release criteria have to be fulfilled as discussed before, and of course always pray when you release the device. And how to treat device embolization, we have covered this during the discussion. And finally, thrombus on the device. Well, clots come like terror attacks. So it can happen on all devices. It can happen with Coumadin, without Coumadin, with NOACs, without therapy, of course. Also, it's unpredictable. And this is a bad example of a very mobile clot on an ACP. How to manage thrombi? You should give anticoagulation if possible and observe. And some patients have been sent to surgery, but I would not recommend that because when you have a patient without device in place and a thrombus, you also would not send them to surgery. Just wait until the thrombus disappears over time. So I think with that, we should stop here. And if there are any additional questions, then we can discuss them.
Yes. I think we can, our panelists, do you all have any questions to Dr. Horst? Yeah. Both the panelists have a lot of experience in LA closure. I'm sure there are practical problems they faced with some cases which they could ask Dr. Sievert. Yeah. Dr. Hazra, any?
No, it's a very good lecture. And I don't have any question right now.
Okay.
It's so elaborative, yeah.
Yes. And I think there are one or two questions, I think, was about septal puncture. I think we did answer them. So septal puncture is posterior inferior. Still try to avoid a very thick part. Try to, let it's still in the, thin part, and it's where possible. I think next question was speech is by Dr. Hazra. So Dr. Hazra is consultant in Amri Hospital, Kolkata. So Dr. Hazra, over to you. After your presentation, I think we could have some discussion. Yeah.
Yeah. my special tribute to Ranjan and Dr. Horst Sievert. Horst Sievert, I learned from him, Dr. Ranjan Shetty in India, but I learned a lot of things in the cloud and YouTube from Horst Sievert. He may not be knowing it. So just like my teacher. And before presenting any case anywhere in India, I always go through his collections. So again, we have LA closure talk today, and these are the different varieties of LA. If you have anterior LA appendage, you go posterior. If you have posterior, go anterior. If you have a lateral, go in the middle fascia. And these are the anatomical things. Sometimes it looks like a rabbit horse. Now it is like a worm, chicken wing. And these are the structure are there in human body, but doesn't serve much purpose except producing BNP and BNPs, but can kill somebody having a thrombus. So it's a parchment-like, very thin structure. Light can go through and through. And they have different varieties. So you'll be surprised to see different names, food names, flower names there with the LA. But if I ask you, are these from same patients or a different patients? You'll be surprised they are from the same patient. Actually, how do you look these appendage, whether you are looking at echo on the angiogram or CT scan, the same appendage may look different. And there are varieties of left lateral appendages, but same appendage can look different on different modalities. So this is last week ACC 2021, the large registry data, 38,000. And what they have shown that this LA closure device can reduce even ischemic stroke by 77%. And you can put this LCDR data somewhere here below Prevail, below Protect. So it is no doubt that it is one of the device or a strategy to prevent stroke. And in this outcome trial, this is published last week in SCC 2021, it does reduce ischemic stroke and mortality, but this is again surgical. Now, in our institute, we have simultaneous concomitant procedure like LA closure with your TAVR, LA closure with micra, LA closure with the ablation. So when you go for PVI first, symptom relief, all types of ablation catheter are possible. But if you go for the LA closure first, you have to stop at the NOAC early. Disadvantage, PVI first 90 days waiting for NOAC before LA closure, you might get a stroke. But if you have LA closure device first, then the inferior surface of the device is very difficult to ablate. And especially it is very, very difficult if you have this kind of device, amulate lambre, and this kind of substrate are better off with Watchman device if you are going for PVI or pulmonary vein isolation in atrial fibrillations. If you have a clot, it's better to wait, as Horst Sievert has mentioned. If you have organized clot, you can have a walk-in kind of procedure, like you make a balloon or make a fish mouth kind of thing in the pulmonary vein, and make a slowly, gradually, you enter in the LA appendage without much manipulation of your guiding or pigtail. And sometimes people are, if you are luxurious, you can put a cerebral protection device if you really want to do it fast, and you can get this kind of clots. Waiting is the best. So which one? Very short LA, amulate and lambre. If you have very small LA, again, amulate or lambre. If you have multiple lobes, again, amulate or lambre. Thrombus in LA, amulate lambre on Watchman flex. So most of the LA can be closed by this, and you know where to go. As I mentioned, most of the time is inferior posterior, but it's not a fixed rule. If you have ASD device, you can go by the side. With a cord-free, you can go anterior, little anterior, if you know that your appendage is posterior, so on and so forth, but it must be guided with your TE. On the table, if you put your tube image on the scalp, it is 0 degree and epicranial. If you put your tube on the right shoulder, it is 45 degrees and narrowcranial. If you put your tube towards the liver, it is 90 degrees and narrow 30, and right gun is 135 degrees. So arteriocaudal gives the maximum angiographic length and the diameter. So this is a working view. And always remember that LA appendage, there is certain procedure, we follow the clock. So LA is always not here, not here. So in cranial or caudal, you have this kind of landing zone of the appendage structure. So it has to be between 1230 to 230 max to max. And When you enter with clockwise loop of the sheath, and if you once you are there in the LA, then you go anti-clockwise to go anterior. So always go through this T-guided SVC, IVC kind of thing. Give heparin, as Horst has mentioned, 50%, and there is certain advantage, very good anchoring mechanism. Nobody has lost lambrey so far. Multiple size, special size are possible, and this has already been discussed. Now, I want to tell you one thing. If you have this kind of anatomy, two lobes, and they're separated by a partition, you have a difficulty because you have less functional length. And if you have less functional length, the watchman cannot go in, only one device can go in, and this is lambrey. Now, this has already been seen. Once you have this device placed, you have this kind of configuration. This button goes in, so less chance of DRT, device-related thrombosis, and it actually occupies both the pulmonary ridge and the mitral valve, and it is usually 2 millimeter shrinkage of the disc if you are overhanging the mitral valve. So once you release, actually it goes in, concaves, saucer-like, and you lose 2 millimeter of the disc. So it is better to go oversize, and all these LA may look different on PE, but you have to have an angiogram. So 62 years female, CKD CHA2DS2-VASc score. Now we know that if you have a moderate MR, you can reduce one CHA2DS2-VASc score to 3 anyways. She was on dialysis, maximum 7 millimeter landing zone like your SCP. So you have chosen 22 millimeter because I'll be getting around another 6 millimeter, 28 millimeter to cover this area. So this looks quite wide. So you have to go for angiographic thing, and this is the pigtail. There's two views. So once you are sure that you have entered the appendage, you should not change your position because your function is so good. You can either enter the appendage or in the pulmonary vein or nowhere. So if you have entered in the appendage, there's no point losing the positions, pigtail, and just glide the sheath. There is a 10 millimeter length between these two markers. And once you are in, do the angiogram, push the device loaded, just little pull at the last moment so that you know while pushing the device, you are actually screwed enough. If you lose here, you have to remove by a snare, then reload it. But this is the last moment you can get to know that your device is screwed. So move slowly, and first the head opens, check the angiogram, then it is like, you have to open this head like this. So this head, once the head is open, these two horns actually grabs. This is the bigger hooks and these smaller hooks. So these smaller hooks will grab the LA wall, and the bigger hooks immediately turns like your mitral pacemaker. It's very, very traumatic. So once you have this, then you have this kind of, again, saucer. Check that. Check your tug. Once you give this tug, then this saucer becomes your American football or Indian idli. So once you have this trigone separate thing, then you release the device. And now people can do on eyes. So once you have eyes to the same hole, you can go there. Eyes can demonstrate the thrombus. You can go for CT scan measurement. If you lose, immediately throw a innovative there. So that will kind of fish net, and you catch the fish immediately so that it doesn't travel into the alveolar aorta, and always snares from the vein. If you have the micra pacemaker sheath, it is 27 French, always better on the venous side. For the arterial side, it's better to grab both ends so that it becomes stretched and it becomes a straight line. And sometimes it helps to immediately heparinize, device delay thrombus. So ladies and gentlemen, let me finish here. Most of the LA appendage can be closed with lambrey as such. But if you really are having living in different geopolitical areas like US, you can use Watchman Flex. Just because lambrey originated from Dr. Lam's lab in Hong Kong, not much seems to be inferior. Very safe device, like any other device. So these two devices can solve most of the problem. Over to you. Thank you.
Thank you, Dr. Hazra, for a wonderful, very interesting presentation. Dr. Purohit, you can upload your slide. Meanwhile, I think there's one question which I can ask Dr. Horst at this time. At times when there is multiple lobes, how to choose which lobe to target? Sometimes the question is, if there are 3-4 lobes and you want to target, this is by Dr. Gautam, which lobe would you target, Dr. Horst? Yeah.
Sorry, I was muted. So I would usually go for the most anterior and most cranial lobe, because that forces the cover to be in a good position at the end. But sometimes, in some cases, I also put the device into the inferior posterior lobe. So, but primary strategy is anterior superior.
Dr. Purohit, can we have your slides? Yeah. Okay. Thank you, Dr. You're on mute, Dr. Purohit.
Yeah. Can you see me now?
Yes, and here, yes.
Okay. Yeah. So, thanks, Dr. Ranjan, and for giving this opportunity. And it's a pleasure to be on the same forum where the pioneer of this entire technology, Dr. Horst Sievert, is there. So it's a great opportunity for us to learn from him. So I'll be presenting, a lot of talks have gone off. So I'll be presenting one case which I did with the Lambre device, and I think that was the device which was suitable for that case also. And this gentleman was a 76-year-old gentleman, had a diabetes, hypertension. He was on a permanent pacemaker. In the past, he had a angioplasty to LAD, and because of his atrial fibrillation, he was put on apixaban. And this gentleman came to our hospital with acute hemorrhagic stroke, for which the EVD was placed, and then subsequently after a week it was removed, and the patient recovered, and he was conscious. He started moving with a very minimal residual disability. And he also had a very critical renal artery stenosis, bilateral renal artery stenosis, because his blood pressure used to be all the time 160, 170, 180, despite 4 or 5 drugs. So when we evaluated, we found that Doppler-wise there was a bilateral critical renal artery stenosis. And so going by this, when we calculated his Chadwick score, it was 5, and his Hazra score was 4. So he had already had a major bleed. So the option for this very old man, 76-year-old, was that we discussed with the family about the procedure of LA Occluder, and then in the same time we wanted to do the one renal artery stenting just to control the blood pressure. And if you see, this looks this is how the anatomy looked. And when we did a T, and when we started doing the septal puncture, it was the septal anatomy was very, very difficult to puncture. So we had to tried multiple times. We had to bring down the septal puncture needle, and with the help of the T and the fluoro guidance, we were able to puncture. You can see how the puncture looks, but in T wise, we were sure that it was posterior and inferior, and that you can know when we tried to push the sheath. We could go straight into this is the left upper pulmonary vein, and that is the standard we always tell, because you should do all the exchanges in the pulmonary vein rather than doing it in the appendage, because the appendage is a very thin part. So if you try to put a stiff wire there and try to do exchanges of the sheath, there is a possibility that the wire may cause perforation. So that's why it is always recommended that you put your the LA Occluder deploying sheath by putting the stiffer wire in the left upper pulmonary vein and then do it. This is how the sheath was introduced, the double curved sheath. And when we did an angiography, you can see it was a typical cauliflower. And what is interesting is we found that there is a big lobe here, very early lobe, just after the origin. And this is how the appendage looked. Right? This is the cranial view. And if you see here, it was a very large orifice of this patient. And here you can see the orifice looks pretty large. But what was more interesting is this early lobe, which we are seeing here. So the question was what size to choose. When we did a TE, it was coming somewhere around 24, 25 like that. And so this is how the anatomy was for this patient. And this is what the various devices we have. in India, we have this ACP, the Watchman, and the Amulet, and recently we have we are also having this Lambre device. So these are just a brief about the different devices. The advantage of Lambre is it can be introduced through a very short, very small sheath, which is of maximum 8 to 10 French diameter, whereas all other devices you need at least 10 to 14 French sheath. And what is very interesting with Lambre devices, it comes in two different sizes. One is a special device, another is the conventional one. The little bit has been told by Dr. Ranjan also, that the conventional devices, the difference between the umbrella and the proximal cover is between 4 to 6 millimeter. Whereas in the special situation where you have a double lobe, or when the origin or the orifice is very big, you can always choose a device which is special, where the proximal cover is almost 12 to 14 millimeter big. So if you have a distal umbrella 16, then the proximal cover will be 30. And and then subsequently it will be, if you have a 18, it will be 32. And after 18, it becomes, the difference is around 12. So from 20, 22, 24, 26, the umbrella the cover will be 32, 34, 36, and 38. So when we saw that our landing zone is somewhere around 23, so we decided that we will go ahead with a device of 26, because that was the maximum which we had. And because the orifice was big, so we chose this special device of 38. So this is how these special devices help. I think that was one of the questions which was asked also, that you choose a device and the proximal cover will always be able to cover the mouth so that you don't have leaks there. And this is what was there in our patient. We chose a device, the umbrella was sitting in the main ear, and we expected the proximal cover to cover the mouth.
Before that, we have Dr. Deepak with us.
So this is how we tried to go ahead with the initial implantation, because as you said, it's a very large LA appendage. So we chose at 26-38, and when we tried to enter the first device, the anatomy, it was not holding, it just got popped out. Maybe we were not too deep inside at that point of time, because this was the initial stages of our Lambre implantation. So this is the experience we had with this. So good thing was this device can be recaptured well, and then you can again reposition it, because there is a double sheath. You can give a little anti-clockwise, it will go more deeper inside and more superior and anterior. And then here we went little more deeper inside, and we gave a tuck test. It looked pretty good, but if you see angiography in the T also, we found there was a significant leak. And here in the angiography, you can see the outer margin, there's a significant gap is there, through which there was the leak was happening. So we just wanted to reposition. The good thing about this device is, because of this hinge point, the device can take various shapes based on the anatomy of the appendage also, without causing much trouble to you, which is the amulet or the CP, although they also have a hinge, but the ability to flex at that hinge point is not that great. So we recaptured the device. You can see the leak here. So we recaptured the device once again, and then tried to realign it. And then after realigning, you can see we have pushed the device, and this is how it looks. You can see it has sealed well, and in the T also it looked very nice. And we did a tuck test. This is how the tuck test looked. The device is absolutely properly anchored, and as most of the speakers have told, there is hardly any evidence or hardly any case report where the Lambre has actually dislodged. So after this, we deployed the device, and the hooks were released, and we did a check shot. You can see the proximal cover is absolutely covering the mouth, and in T wise there was no leak at all, and the patient was discharged successfully. And then subsequently we went ahead and did the procedure for the renal artery, and then this is the procedure was completed. So I think this is an interesting case where we had a proximal early lobe, and we had to use we were fortunate that we had this Lambre device, and we were able to successfully close this LA appendage. Thank you very much.
Yes, thank you, Dr. Purohit, for a wonderful talk, and also I think the point everybody's trying to make is, it's not just about landing zone; it's actually where you land the device also later, and there's no one number. You may have to go in and out. Dr. Sievert did make these comments. So I don't think so. I am not seeing any further questions here. Any of the panelists have any question for Dr. Horst Sievert?
So I would ask Dr. Horst Sievert how he would have done this case. Any special tips he would have suggested to do this kind of difficult anatomies?
You showed very beautiful technique, and this device, this is really one of the big advantages of this device, that you can close this kind of appendages, which is almost impossible with the other devices. So that's for sure a big advantage. The other advantages include, and this has also been discussed, that this device does not embolize. At least we haven't seen any embolized devices. Another advantage, it has actually a number of advantages. Another one is that it requires only a 10 French sheath. And you may say, okay, it's a venous procedure, it doesn't matter. But we have cases where it was actually quite difficult to insert a 14 French sheath over a stiff wire into the groin, if the patient is obese, if there is some unfortunate tissue. So it's actually an advantage that you can use a 10 French sheath only, even for the largest devices. And what they also can do, I don't know whether this is available in India, if you encounter a case where, for example, the appendage is too big for all the currently available sizes, you can call them and they can make a special device of almost unlimited size for your patient. So yes, they are very flexible and cooperative, much better than other companies can do.
Thank you, Dr. Horst. I would ask one question. What would you do if you have a very early lobe, like hardly any neck? It's something like a chicken wing or a reverse chicken wing where it bends immediately. How would you close such appendages? Yeah.
Well, then it really depends upon the details. I mean, we had some cases like that where you have almost no landing zone and it immediately turns around into the chicken wing configuration. So we have cases where we put a smaller device distal into that chicken wing. That's an option. I mean, when you think about your cases where you have seen clot formation in the appendage, where does it start? It usually starts very distally. It does not start at the area of the landing zone. So that means if you can close a more distal part of the appendage, that is also some benefit for the patient. It's always the aim to occlude the entire appendage, but if that is not possible, you can consider to implant the device more deeply into the appendage.
Thank you, Dr. Horst. We are
So what are the related thrombosis? What are the predisposing factors as far as the device related issues are concerned? The type of device, the brand of the device for DRTs?
I could not completely understand the question, but I think it was predictors of device-related thrombus, yes, right? Okay.
Yeah.
So far, there are no good predictors. So it's not really device-dependent. It's not really depending upon the post-procedural treatment. So we actually don't know. I mean, part of your question was, are there any clotting disorders which are a predictor? I'm sure they are, but this has not shown up in clinical trials, maybe because these clotting factors had not been analyzed. So there must be some predictors, but actually we don't really know.
Does it relate to any device make or type in any way? Yeah.
Not really. I mean, it also depends a lot upon the definition of a clot. And this sometimes sounds trivial, but it's not trivial. And when you send one picture where you think it's a clot to different echocardiographers, some say, okay, there's nothing. Others say there is a clot. Others say there is something, but it's not a clot. It's tissue. So it's really, there are many borderline cases, and that explains why the incidence of clot is so different in different trials. You have trials with the same device where they have found 2% incidence, and then with the same device, another study group found 16%. That's the case, for example, with Amulet, and I think there are also studies like that with Watchman. So this needs really more evaluation, and it has to be defined what is really counted as a clot and what is not. The same issue is with residual leaks. We need more firm definitions how to classify and agreement what is a shunt, what is a clot, and so on.
Yes. Thank you, Dr.
One
Horst.
question, Dr. Horst.
Yeah.
These atrial fibrillation patients, many times the electrophysiologists go ahead with doing ablation. So what do you think? Because we know that ablations, they do not give permanent resolving of the AF. Many times they come back again. So why not implant a device when they are doing ablation? That is one part. Second thing, I am seeing a lot of reluctance among the electrophysiologists to adopt this technology. Any specific reason why the electrophysiologists are not very keen to implant the device in the patient who are having atrial fibrillation?
Well, the second question first. So I think this varies upon the country and the setting. So, for example, in the United States, it's a big turf battle between EPs and interventional cardiologists because everybody wants to do it. So this sounds to be different in India. I think in Europe, in Germany at least, well, it's not a turf battle, but both specialties do it. So the first question was, why not to combine this? Impossible in Germany for reimbursement reasons. We would get reimbursed only for one procedure. But putting this aside from a medical point of view, what we do if we have a patient who has indication for both, that means ablation because of symptomatic AFib and contraindications for anticoagulation, we first do the ablation. And that is because it may be that the patient needs another procedure, another ablation. And as discussed before, it's easier to do an ablation if there's no LAA occluder in position. So we do the ablation, we wait for the result, and after 3 months, then if the patient is symptom-free regarding his AFib, then we do the LAA closure. But I mean, there had been cases to combine this. There had been cases the other way around, do the LAA closure first and then ablation. I think all this is possible.
Yes. We do have two questions. One is directly entering into LAA versus exchanging in left upper pulmonary vein. What do you prefer? Any particular orientation there? And second one is the anticoagulation post-procedure. What's the preference? Yeah.
So my personal technique is actually the opposite of the technique of most other operators in the world. Mm. And again, that's because I started that way. So I go in with a pigtail into the LAA, and then I use a wire and exchange over the wire. But what is important here is to use a wire like the Amplatz extra stiff with a J-tip and with 3 centimeter long tip. If you use the other Amplatz extra stiff, which has, I think, 10 centimeters long soft tip, it's much more difficult and maybe also more dangerous. And also if you use Amplatz super stiff, or those who have a shorter soft tip, then the tip of the wire does not conform like a pigtail catheter. And again, with a 3 centimeter tip, you can easily exchange in the appendage. And if you pay a little bit of attention, then nothing happens. And also this is a discussion in all the LAA courses. And then I defend my position and ask the audience and the panelists, okay, how many perforations did you have using the wire for the exchange in the appendage? And then the answer is, oh, we never had that. So it's safe if you do it carefully.
Yes.
And the other one was
anticoagulation post device. Yeah.
Yeah. So we give aspirin for 6 months and clopidogrel for 3 months, and then we stop everything unless the patient has an indication for something.
Something else. I think the one this one would be by one more person. How would you rank 3 major devices available commercially? Question by Dr. Lakshmi. What's your top choice? Yeah.
Have the Watchman Flex, and the Watchman Flex is so much better than the old Watchman that I think all of the devices do a good job. In your situation, you have the old Watchman that has some disadvantages. And the biggest advantage of the old Watchman is the landing length, the functional length. Yes. And eliminate some of the patients, maybe 5% of the patients cannot be closed with the conventional old Watchman because the appendage is too short. So in that regard, the other devices are better. And then when it comes to differentiation between lumbar and amulet, both do a good job. Success rate is high in the 90s. I think it's operator preference, and we have discussed some of the advantages and disadvantages of these devices, so it's difficult to rank them really.
Thank you, Dr. Horst. It was really wonderful. I hope we will have you for some of the sessions in future. Also, I'm, before I just conclude, your CSI conference is one of the best conferences in the world, and I've been attending it for some time now. I'm also told there's one this year, and you want to invite all of us. We'll be happy if you can, invite all of us and tell the date with that. Yeah.
Oh, we have several conferences. We have one with live transmission last weekend of June. And then we have the LAA course in October. We have the heart failure course in December. We have a CSI America also in October. And the next physical CSI in Frankfurt will be next year. So if you check our website, which is CSI-congress.org, you can check all the different conferences. I would like to see you there.
Yes, thank you, Dr. Horst Sievert. Yeah, I think the first conference I must have attended some 8 years back, and I really liked it, and it's different from so many other conferences which we attend. Thank you, Dr. Horst. And we are almost running out of time. We have had around 510 participants and from 83 countries, and it's been great. So thank you all the participants for participating and having a very active discussion. We would have next session on June 19th, which would be, I think, third Saturday of June, and we will also have most likely we will definitely have a foreign proctor who would be participating, international speaker who would be participating with us. Thank you very much, Dr. Horst Sievert. We have learned a lot from you, and we have had a very wonderful discussion. Thank you, Dr. Two of our other panelists, Dr. Hazra and Dr. Purohit. It's been great, and the Lifetech has been, they are the ones who have really managed the technical part and brought all of us together. Thank you, Satya and his team. Hoping to see all of you on June 19th, where we are going to discuss more technical aspects of LA closure. Thank you, and have a great weekend ahead. Yeah.
Thank you. Bye-bye.
Yeah, bye.